All right, I'm going to go ahead and call the meeting to order. We're going to give people a couple minutes to get started, but I don't want to run over too much time. Hello, everyone. I want to thank you all for being here today. I really appreciate you guys taking the time out of your afternoon to meet with me. I just want to go ahead and start. So welcome to the January 2021 Overdose Fatality Review Team meeting, the first of many, I hope. I want to go ahead and start with some introductions. So if we can just go around, I'll introduce myself and then I'll just call everyone's first name that's in the meeting right now. If you can just state your name, what organization you're representing, and your title if you would like to, we'll start from there. So I'll go ahead. My name is Jordan Crummett. I'm the public health educator here at Knox County Health Department. I am the coordinator for the Overdose Fatality Review Team. And I'm very happy to be here with you all today. So I'll just go down the list here, and if we can just get everyone's introductions. First is Candace.
Good afternoon, everyone. My name is Candace Allen. I'm with the McNabb Center. I'm Senior Director of our Adult Intensive Outpatient Programming.
Great, thank you. And Amy?
Amy Delinky with the Knox County Health Department, overseeing the All for Knox initiative.
And Brian?
Hi, my name is Brian Wimbigler. I'm a pharmacist and I teach pharmacy at UT College of Pharmacy on the Knoxville campus, and I specialize in teaching our substance use disorder related content in the curriculum.
And Chris Thomas?
I'll just jump in. He might actually be in the dentist office just listening and cannot talk.
No,
but I'm definitely. Oh, are you here? Oh, here you are.
Sorry, man. I thought I hit my unmute button. Chris Thomas, Chief Administrative Officer with the Knox County Regional Forensic Center.
Great, thank you. And Darinka, go ahead.
I'll just jump in. Thank you. Sorry about that. I am Darinka Milusnik, Medical Examiner for Knox and Anderson counties and Medical Director for the Regional Forensic Center.
Thank you. Chris McLean.
Good afternoon, everyone. I'm Chris McLean. I'm the Clinical Manager for AMR Ambulance Service.
Thank you. Jennifer.
Hi, I'm Jennifer Torville, Director of Substance Misuse and I forgot my title apparently. Director of Substance Misuse Outreach and Initiatives for the UT system.
Great. And then Karen.
Afternoon, I'm Karen Pershing, Executive Director of Metro Drug Coalition.
Thank you. Lauren.
Hi, I'm Lauren Allard. I will be serving as the contracted evaluator from the Tennessee Department of Mental Health and Substance Abuse Services for the federal funds tied to this project.
Thank you. And Michelle.
Hey everybody, I'm Michelle Trofeter. I'm the Public Health Analyst with the Overdose Response Strategy CDC Foundation.
Thank you. And Phil?
Phil Major. I'm a sergeant with the Knoxville Police Department, and I am the Task Force Commander for the Drug-Related Death Task Force here at Knoxville.
Thank you. And then Sam?
Good afternoon, everyone. I'm Sam Lee. I represent the Knox County District Attorney's Office. I am the Chief Deputy.
Great, thank you so much. So that's everyone we have right now. I know we are missing a couple people from the team who had some other obligations today. So we'll check in with them later and I'll be sure to send these minutes out. But thank you all for that. Next on the agenda, we have our approval of minutes for prior month. This month, we don't have any minutes to approve, so that's taken care of. Next is setting the agenda. So for the rest of the meeting, we're going to go over the data analysis portion. Then we're going to move into some brainstorming and discussion sessions. And then at the end, we're going to talk about some action items and some other business coming up. And then we will adjourn at 4 p.m. So first, I want to talk about the open meetings. So as you all know, we are in an open meeting right now. Our meetings are now going to be held on Zoom through the Knox County Health Department Zoom account. I'll be updating the calendar invites for you all with the new link every month. And these meetings are open to the public. So we are live streaming on YouTube this meeting, and other people from the public and media can join as they see fit. So just as a reminder, and if you all have any questions or anything you want to ask during the meeting, feel free to use the chat feature. If you don't want to unmute yourself, if you do want to unmute and ask a question, feel free to do that as well. It might be easier to save them all for one section, and then at the end of the data portion, I'll go over all the questions that I haven't yet answered. So I'll have the chat feature open here, and I'll be keeping track of those so we can address them when they come up. Next, I want to hand it over to Chris Thomas. Chris has some relevant data for us to go over from the most recent years. Again, I know he just introduced himself, but Chris Thomas is the Chief Administrative Officer with the Knox County Regional Forensic Center. He's in charge of their data, and he's pulled some information together for us today. So Chris, go ahead. Thank you very much.
Thank you. Well, first of all, huge disclaimer is that this data is not complete. So I do have the 2020 data up to the point we've collected. So anything that you see here, if you say, well, it looks like it's tickering off towards the end of the year, that's not an actual factual statement. All I'm doing is including the things that have already been certified as drug-related death. There are still over 300 cases from 2020 that have not been finalized. So those will fit into some kind of category, no matter what they are. So I've been trying to this year provide more up-to-date real-time data from where we're at and what's been certified. So that's where a lot of this data comes from. And I don't remember what pages I've got it in order, but you can go ahead and go to the next page if you want to, that's fine. So what I've tried to do is just show a month-by-month category of the deaths that we've had that have been drug-related. As you can see, the green is 2020 data. So we've just about gotten through October, and a lot of November, December still has to be done. We actually still have quite a bit of October, November, or September, and October as well to be completed. But as you can see, the green is very overpowering in this chart. I did read that there was an article published on the CDC website that you can go out and see that says that the period of June 19 to June 20 was the highest drug-related deaths ever on record for the country. So we're certainly no exception in East Tennessee. Everybody was experiencing drug overdose data. I'm very grateful that we brought on a fifth pathologist in July because the sheer volume of the numbers were staggering. We've had over total our department, I think we're right at 700 overdose fatalities we've handled through 2020, and I think 370 of those were Knox County cases to this point. So you can just see for yourself. I decided not to compare just last year to this year because sometimes you don't get a true picture when just looking at year over year, because 2019 was a really low year and we were glad for that. But even going back to 2018, I know the numbers of the drug-related deaths that we've had in our facility have far exceeded anything that we have on record. So that's pretty apparent here in the numbers. And you can go on to the next page. I'm not going to take a lot of time on it. And so we do break it down by the age distribution. As you can see there, the large portion of that's the 35 to 44 age bracket, but then just right behind us, the 45 to 54. And then it kind of goes from there. And the 25, the really great news that I was really proud to see is we had almost no drug-related deaths of minors. In previous years, we may have had one here or there come through, but I think pretty much every case was about 22 and older this year. So I'm really glad at least the younger population is getting it. So as you can see, it's kind of evenly dissected there between the age ranges of 25 to the 65 age range. They kind of break it up in those four categories. You can go on to the next page. And this is just breaking down you can actually see the numbers from last year to this year. You can see the staggering differences. It was a little concerning that we've had a large jump in that 55 and plus population. of drug-related deaths. So you can see almost the 55 to 64 numbers have almost doubled from 45 to 80. And then when you take in the 65 to 74 and you add on the additional cases there, just about doubles from that 55 and up population, which is not a trend that you'd hope to see. Don't know really all the triggering effects behind that, but those are the facts, and that's all I can report. I think there was maybe another slide after that one. That was just breaking up the gender differences. Most of the overdoses are male, of course. It's almost a 2-to-1 case on that. So really no change there. Other than the increased amount, of course, going up from the 19 data to the 20 data. And then go on to the next page. You can see in East Tennessee, it's primarily white. Almost every one of our cases are white. We have a very small population of Black or other races that are dying from these overdose-related deaths. So it's pretty much all white there. Listen, just barely 10, at least 90% of it. And I think, was that the last slide? Oh, and then just the number of analytes. So I do like to show the number of cases of what type of drugs we're finding out there, and there is a slew of them. Fentanyl, of course, is the most populated drug in our market, 321 cases. This is just the Knox County cases, of course, and some had different types of fentanyl broke in, and there is a new one that has kind of emerged in late December, early January. There is a parafluofentanyl, I believe is the pronunciation of it. I think we've had maybe 4 cases of it, but those cases have not been certified. That's why you're not seeing that data. Opioids have really come back into play here. A lot of people using prescription medication, methamphetamine, and then of course heroin and cocaine have really made us resurgent. It seemed like heroin has really kind of came back strong this year from previous years. So I don't know if it's accessibility or just the cost of it, but as you can see, those are the number of cases we've found in Knox County cases alone. So of the 360 something Knox County cases, there's how many times we found those drugs in each one of the cases, and some of them are more than one. Some of them will have fentanyl and methamphetamine or heroin as well too. So it's unfortunately it trended the wrong way. January's not been any exception. The doctors say we've seen multiple overdose cases on a daily basis, and it's a pattern that I'd like to see turn around, but it is not at this point.
Thank you, Chris. Does anyone have any questions for Chris before we move on?
Chris, I've just got a quick question. Jordan, if you can back up a few slides, the green bars where it shows, keep going. That one. Chris, all the green bars top out at 40 right there. Is that a data limitation issue, or is that true reporting?
That is actually true reporting. I can actually see the numerical data. It actually was. I literally had 4 months in Knox County, and those are the highest months we ever had, where there was exactly 40 overdose deaths reported. Yeah, it looks like that maybe there's some kind of line and limit, but no, those are the true numbers.
Okay, that answered my question. Thank you.
It's not often that your true numbers make a chart look perfectly even, but
yeah. So I thought that was an anomaly, but it's good that you just reinforced that it is what it is. Thank you.
Great. Anyone
And
else?
I just have to add that most likely in November, especially December, we are going to exceed that. That's at least my feeling based on the cases that we are still working on. So that what you're seeing in November, December, that's just very incomplete and early data. It's going to surpass, I think, that magic number of 40, which is really kind of peculiar.
what's really even more terrifying about the December numbers, if you look at this chart right here, you see there's a lot more green in December than November. And that's not because we've completed more December cases, but December was our center's all-time record high in every category. We never had as many deaths reported in the month of December. We never had as many scenes that we had in the month of December. So those are the ones that were pretty much found right away. Whereas you still have the same amount, you have a couple of hundred cases, several hundred cases from December that still have to be completed, and several hundred in November. So yeah, December, when it's all said and done, will probably be our largest month ever, be my guess.
This is Karen. I had a quick question. On your chart that showed the substances found, yeah, the
Yes.
very last one, opiates, is that heroin and prescription drugs together?
It's subscription drugs, and I apologize, I don't have the list of all of them. It was not the heroin. The heroin was set aside on a separate category in the analytes that fall under it, but it was just everything else: the hydrocodones, the oxys, there was a list of like 10 or 15, I think, or maybe like 8 or 10 different opioids that we had identified that were classified as just opioids in general.
Actually, we're going to correct it. It's opioids. It's
Right.
It's opioids, and it's going to contain all the others. And we had some others, new synthetic novel opioids that showed up that, of course, are not under the heroin or fentanyl category. And I have to add one more peculiar thing. What we're seeing increase in, and we might actually separate it in a different category, is that alprazolam is coming back again, being combined with other drugs, and alprazolam, which is very, very potent and by itself is actually very deadly. And finally, mitragynine or kratom, it's becoming big, and people are consuming it in huge amounts. I believe you can purchase it in, I guess, CBD stores. I've seen it in sometimes I just walk through the flea markets. I've seen it sold at flea markets. It's becoming a problem. But that's going to be reflected in a final summary of the cases.
Thank you. Thank you for that. Does anyone have any other questions or comments before we move on?
And I think, in the end, when it's all said and done, when we analyze this category, I guess, was it the 4955 or whatever, 4655? It's always the same problem. I think, that unintended consequences of COVID, the measures is going to be a factor. As you know, pre-existing conditions is something that actually Karen and I talked about, something that maybe we are missing, and maybe we should emphasize that I guess it's related to COVID, and it's related to drug abuse and polypharmacy in general, is pre-existing conditions. Maybe we can actually, I shouldn't say take advantage, because we are really bad situation, but emphasize the importance of pre-existing conditions and overall health. Weight, hypertension, diabetes, these are all big issues that we are, I think, missing the opportunity to educate and really push out the information on the importance of taking care of or preventing, or at least reducing the damage from the pre-existing conditions, which are risk factors in both COVID and the drug abuse. And then finally, as you know, that the providers are becoming more responsible as far as prescribing medications. So the pool of these individuals who seek drugs is larger than ever, and they're resorting to fentanyl or other synthetic opioids, as was the issue before. And so something to keep in mind, and maybe kind of, I guess, when we push for education and then awareness in the community, emphasize all these other issues that are indirectly related to drug deaths.
Right. Thank you. Anyone else? Okay, great. Thank you, Chris and Drinka, for that. I just wanted to make sure that we had a good basis of some most recent and relevant data as we move forward, just to give everyone kind of an idea of what we're going to be looking at as far as case numbers and the kinds of cases we're going to be seeing as we move forward. So thank you. I want to move into just some explanatory pieces. This is about our case selection criteria for the 2021 data we're going to be using. I want to make a note that this selection criteria was not used to create the mock review that we're going to be using today. I have that on the next slide. I'll go over that a bit more. But moving forward, we're going to be using the age range of 25 to 44. Our initial conclusion on that was since we are funded through BJA, we wanted to cover those who would most likely be justice-involved individuals, and we're not limiting it to just justice-involved individuals, but we wanted to make sure we were capturing the highest probability of that group. So we've pulled some data from TBI from 2019, which is the most recent set of data they have. And we have found that the 25 to 44 age range fits for our primary data pool right now. Of course, we're open to reassessing that as we move forward, especially seeing the new numbers coming in from 2020. There's always room for changing that set, but for now, that's what we're looking at. I have some of the data pulled here. This is on the left, you see the chart from TBI data. And again, you can just see the prevalence for male and females, that the 25 to 44 age range is the most widely included for justice-involved individuals in 2019. We also have some information from Knox County Sheriff's Office that covers those incarcerated in Knox County. Those are the average ages, and that's also from 2019. So I just wanted to put that out there for now. Again, as I said, this is something we can review in the future and kind of discuss if we want to move forward with that. But for now, this is what we've settled on. So today we're going to be looking at data from December 2017. Chris was so kind to send us a data set. There were 38 total overdose deaths during that month, and I have analyzed 25 of them for this review in chronological order. I just wanted to make sure we had a large enough set to kind of give everyone a good idea of what the data is going to look like. So the data that I have is all from the Regional Forensic Center, and that includes toxicology reports, autopsy reports, narrative reports of the scene, as well as the case in general, and any other available medical and social history information. So any gaps that you're observing in this data set are likely to be caused by the lack of data, which is what we're all here for. So hopefully we're going to be covering some of the gaps that we see in this set with subsequent data sets, using the information that you all are able to provide us, and that's really the main goal here. So for future meetings, we're going to be using the most recent data from the previous month, so that'll be 2021 data. Moving forward, February will be our first month using 2021 data. We'll be reviewing 3 to 5 cases each month, and they will be pulled randomly from the cases that the Regional Forensic Center has. Again, I know we've discussed this before, but I will send that case information to you all. We're going to be using case numbers. So I will send you the identifying information, but when you send back your information to me, you'll identify them by case number. I'll collect that data from you all, and then I will provide the data analysis and findings at each of our monthly meetings. So this is just kind of a look forward at what it's going to look like. And today we're using this as a demonstrative kind of trial run, if you will, to see exactly how that's going to function. So getting started, I'm going to go over some basic demographic information. This is the age and year. So as you see, we have a plot here. Again, our largest buckets in Knox County in 2017 were in the age range of 20 to 35, as well as the age range of 50 to 65, which is a little more common in Knox County, as we saw from Chris's information as well. Down here at the bottom, you can see our youngest, our oldest, and then the mean, which is a bit skewed because of the amount, as you can see in the plot. So I'll give everyone a second with that. Moving forward, this goes over a location of the overdose incident. As you can see, a majority of decedents are having their incidents at home in their own residence. The next closest is in a motor vehicle for this data set, and then it's pretty spread with the other few. This is pretty common. You can see 20 of the 25 cases were all in their own residence. This goes over the evidence of administration. So how were or was the drug administered? This is based on evidence at the scene and evidence from the autopsy report. The majority of cases had evidence of injection or no information on the route of administration. Again, this can be caused by a lack of data or just not a clear route. The way that REDCap collects data, it's always known information or explicitly stated information. So I'm not pulling my own opinions or my own assumption of what happened. I'm only pulling the strict data. So if you do see something that has no information, it could just be that it was not explicitly stated, which is why it's not showing here. But again, you can see the highest incidents are evidence of injection, and then after that it's evidence of snorting, evidence of smoking, and evidence of ingestion. We had 3 cases that had evidence of multiple routes of administration, which is accounting for the percentage increase. You can see it's 108%. So just keep that in mind. That some of the other numbers are like that as well, where there's evidence of multiple things. So the numbers will look a little different. Moving forward, this is substances found at the scene. This is types of substances found at the scene. 10 cases had none found. 10 cases are in the other category, so not one of these listed. The listed categories are tar, prescription for an undetermined individual, prescription for the decedent, any sort of powder or packaging, over-the-counter medications, illicit pills, diverted prescriptions, and crystal. So again, some of these were not noted in the case at all. I have a breakdown.
Can you define tar for us, please?
Under red cap, tar would be
like tar, heroin, or okay.
Yeah, that's how they're describing it. Again, it is noted in the narrative of the scene usually, so it depends exactly how they're describing what they find at the scene, exactly what category it goes under. So it can be variable, but that's how red cap describes it, yes. Thank you. Here we have a breakdown of the different types of substances found at the home. At the scene, sorry. So again, there's 10 where none was found, and then I've broken it down into if there was one type of substance found at the scene or more than one substance found at the scene. So as you can see, a majority of these cases, more than one substance was noted to be at the scene. And we'll show that later on that polysubstance use is the majority of these cases as well. Next is the toxicology results. I know this is a very busy slide. I wanted to include all of the categories that red cap includes as well. So these are all the things noted in red cap that can come from the toxicology report. And any of them that are not listed here that were noted in the toxicology report are listed under other for the sake of not identifying any information. Since we're using aggregate data, I don't have that exact list to provide you, but it does, if it does fall into one of these groups, then I've labeled it as such. So as you can see, a majority of cases had fentanyl in the system. And then in descending order from that, we have antidepressants, benzodiazepines, methamphetamine, amphetamine, opioids, alcohol, and then moving down from there with other prescription medications as well as cocaine. The other category does include multiple different kinds of sources. If there were anything that were outside of any of these categories, I did list them by name and amount. So if we were ever to look at very specific case data, I have that information. But again, in these meetings, we're just looking at aggregate numbers. Moving forward, now we're moving into more of bystanders present and other information about the decedent themselves. At most cases, there was at least one bystander present. So you can see 21 cases, there was at least one bystander present at the scene of the incident. There were 4 where there was no one present. So it's pretty common to have people around when the overdose is taking place. If you look over in the pie chart, a lot of these people are intimate partners, other family, as well as roommates are the most common. Other is anyone that does not fall into these categories. So for example, like a neighbor or someone of that nature would not fall into one of these categories, so they would fall under other. So we have friend, other family, intimate partner, roommate. The other categories that are not represented here are another person using drugs, a medical professional, and unknown. So if a bystander was noted, but they don't know their relation to the decedent, then that goes under unknown as well. Okay. Next, we have information on naloxone administration. In this set of cases, naloxone was only administered during one case. And I have a blurb over here just talking about how in 2021, we can expect to see more cases where naloxone was administered versus 2017. That's due to the increased training, availability, and distribution of naloxone in Knox County. We have some programs with naloxone distribution, as well as training taking place. And some other data points that are included in the naloxone section under REDCap. So these are included under REDCap, but we're not covered for this case. But things we expect to see in the future as far as information and data available would be who administered the naloxone, total number of naloxone dosages administered either by first responders or healthcare professionals or by laypersons or other civilians, reasons why naloxone was not administered if it was noted to not be, and any other issues administering the naloxone. So I think that this set of information is going to be very helpful for our team in particular, since that is kind of a hot topic in Knox County. And I think that we'll have a lot more information with this moving forward with our more recent data. So I think that'll be good to show. Next, we're moving into mental and behavioral health history. So this is the mental health and suicide section. Did the decedent have a known history of mental health problems or diagnosis, such as depression, anxiety, PTSD, etc.? And I want to note that this chart on the left excludes a substance use disorder diagnosis. That's included in a separate section. So as you can see, 10 of the cases were noted to have a known diagnosis. And again, this is just based on the information we're given through the Regional Forensic Center. So I believe that if we did have more of a previous medical information, we would see some difference in this data here. And on the right, we have history of suicidal ideations or plans or attempts at suicide. As you can see, we had 2 cases where that was the case. And again, I think with further medical history and behavioral health history, we'll see some differing numbers here as well. Next is substance use disorder specifically. In REDCap, those are in separate sections, which is good. Did the decedent have a known history of substance use disorder diagnosis? So this is only if it's specifically noted in the case. It's not to be determined based on any sort of inferences. As you can see, 16 of the 25 cases were noted to have a previous substance use disorder diagnosis. And over here on the right, we have a chart that shows what substances the decedent was known to have a history of using. So as you can see, our largest group here is alcohol, followed by heroin, and then anything that falls into the other category. That includes others that aren't listed in this section, as well as if it was not specifically noted. And again, you'll see prescription opioids and nicotine and methamphetamine are also included in our caseload here. Other options included marijuana, cocaine, heroin. So it does run a pretty wide spectrum here. And a breakdown of that, I've listed the numbers where the substance use history included one substance only versus polysubstance use. I think that's something important to cover here, especially with these cases. So as you can see, 1 case was noted to have a history of using methamphetamine only. 2 were shown to have a use of heroin only. 7 cases reported polysubstance use, and then 6 of them had unknown substance use history. And again, I think we'll continue to see numbers trending this way in the future as well. I've also included a section here on co-occurring disorders. So this would kind of give us a better look at some previous history. This includes substance use disorder only is in its own section. That's 9 cases. Someone with a mental health problem or diagnosis only, and again, that's excluding substance use disorder. That was 3 cases. And then we have a section here that's co-occurring substance use disorder as well as a mental health diagnosis. So that was 7 cases. So as you can see, it's a large chunk. And then we have 6 cases with no known history. Moving into our criminal justice history section. Again, this is a section where we are missing quite a bit of information for this specific data set, just based on our data limitations. I think moving forward, we'll have more in-depth information on this. And I'm hoping to see some more in-depth information about not only each specific case, but overall with our aggregate numbers as well. So as you can see, since it is labeled as known criminal justice history, those that fall into the none category was either no arrest, it was in our mind, it's no known arrests. So that's not to say that any of these individuals were not, did not have a criminal justice history, but it's just nothing that was specifically noted in the data. I just want to make sure that that's clear. So we had 4 cases with noted arrests, 3 noted incarcerations, and 1 that falls under the other category, so it doesn't fall into any of these other previously stated categories. Over here we have some further information. We have the age in years at the first known incarceration. So the youngest was 28, oldest was 31. And then we have the number of known incarcerations. So again, there's just 1 known. Not to say that that's the full source of information, but that's what was noted in these cases. Going further in depth, we have the justice system involvement 14 days prior to death. There's a couple sections like this where it lists any sort of interactions with social services, justice involvement, and some other things within 14 days of death, just to give us like a closer timeline of what was going on in the decedent's life directly prior to death. So in this case, we had 2 that were recently released from a correctional institution, 1 that was recently placed into incarceration, and 2 that were recently arrested. And again, multiple interactions can apply to 1 case, which is the case in this set of data. So I know that the numbers look a little off here.
Hey, Jordan, it's Sam Lee. I've got a quick question.
Yeah, go ahead.
Is this information Knox County information, or is it, is there any jurisdictional limit to it?
This is currently only the Knox County information that I have from the RFC. We do have the ability to get data from other places if those people would be willing to be involved and provide data. But for now, this is just Knox County. Okay.
Well, I guess more specifically, like when you say placed into incarceration, is that they were placed into incarceration in Knox County versus severe or blunt or?
Yes.
Okay.
Thank you. Okay. So those are all the specific data points that I've included for this data set. That's just to give you guys a good overview of the kind of data points we're going to be looking at. Again, that's not comprehensive. I know we talked about earlier, there's literally hundreds of data points that I'm entering for each case. So there are some things that weren't covered here. Current gaps that I'm seeing as far as information we don't have just from information from the RFC. We're missing previous medical history, including medications, primary care information, any sort of emergency department visits, prescriptions and their interactions with each other, et cetera. Any sort of previous medical information we can find, I think would be extremely helpful. We also don't have any previous treatment for mental health, substance use disorder, or other chronic conditions listed in the data. We're missing interactions with community health initiatives and outreach points, previous criminal justice information, as I stated before. There's also sections on child services and other social services information and interaction that we don't have data on, as well as any sort of economic, educational, and employment background, which I think would be very helpful to know for these cases as well. So today, I kind of want to guide us into the discussion portion. So I want everyone to be able to take this information that we've looked at and kind of be thinking about what kind of information do you personally have access to contribute to the team as a team member, as a professional, as a member of any sort of community organizations you're a part of that you could share with the team. I also would like everyone to kind of think about, is there information that's not present in this data set that would be helpful for you either as an individual to make any sort of brainstorming of ideas, or to understand each case more in depth, or the set of cases, I should say. I'd also like everyone to be thinking about any sort of suggestions you might have as far as, I would love to see this in the next data set, or can we go into more depth about this section of the data? Any sort of trends you might notice across cases, or any sort of like interesting points of information that you want more data on, or you would like us to look deeper into. And that, again, that can be in any sort of category as far as these cases go. We're really looking to understand the cases as a whole person, and kind of look at all of their interactions, not only as a decedent, but in their life as well. So moving forward in the future, at future meetings with future data sets, our hope is that the team members will fill gaps in data with information from your own organizations or your own involvement in the community. So that over time, these trends and these gaps in data can be assessed and analyzed, and we can kind of see like, where is that leading you to believe that you're seeing some sort of trend, some sort of gap, some sort of need as far as these cases go in a long-term and aggregate way. We're going to use the data available to the OFR team to brainstorm and create ideas, find new ways to analyze and review overdose death data in Knox County. That's really the goal here. The goal is to bring community members together, collect data, analyze it, and then use it in a way that's helpful for all of you and your organizations on an individual level, as well as on a countywide level, to prevent further overdose death in our county. So I want to transition us into the brainstorming discussion section. So like I said before, if you have any questions or anything moving forward before we get into like a deep discussion, please feel free to unmute yourself or message me in the chat. But moving into kind of a time of discussion of, are there things that you've seen in the demonstration that you would like more information about? Are there areas that you want me to cover more in depth in our next meeting with further data? Anything like that, please feel free to unmute yourself or type in the chat and let me know. Does anyone have anything right now?
Jordan, this is Karen Pershing. I think it's really important that we capture as much of the social determinants of health with these cases as possible. And I know that information might be a little bit harder to gather, but I do think it's going to be important to identify potential intercept points and then see where the links and where disparities may be occurring with some of these individuals as well.
Yes. Thank you, Karen. Anyone else?
Jordan, I could probably add in a separate quick access spreadsheet for injury location by zip codes to really get location of disparity amongst the community.
Thank you, Chris. Anyone else? Is there any information that you didn't see that you think would be helpful to you as a team member? Like anything that would make this data set more meaningful to you or pique your interest a bit and give you some more ideas or some more insight into some of the issues we're facing here with the cases?
Jordan, are you going to be showing us an example of what de-identified information we're going to receive from you so that we can, in our own respective areas, if we have access to other things, how we're going to be able to identify those patients in our own respective systems? So are we going to be provided with name and birthday? What kind of materials will we receive ahead of time to discuss during these sessions?
Yeah, so I will send identifying case information to you all. So you'll have date of birth, date of death, name. I think that's the main data that I'm going to be sending as identifying. And again, I'll send them as case numbers as well as that identifying information. And when you all send it back to me, you'll send it back to me noted as case number. So you won't be identifying the information when you send it back, just to kind of protect you all and protect the data a bit more.
Got it. Thank you.
Yeah, of course. Thank you, Darinka. Does anyone have any sort of idea on some trends they're already noticing based on Chris's data, or anything I've presented, or some other trends that you'd like more information on, or something you want us to cover in a long-term case? Something we can track month to month as far as a trend goes that we can look at?
I'd be interested to kind of follow up, and I guess Darinka and Chris could help us with this. Start looking for the kratom in there anecdotally, and kind of the populations I work with on a regular basis. They're using that as a gap between doses of their opioid of choice to kind of get them through that. And then I've seen some others that have transitioned to using that kind of exclusively as a cost-effective alternative to opioids. At those ultra high doses, they act like opioids without that respiratory depression. And then anecdotally, they say they take low doses for a stimulant effect, medium doses for analgesia, and then those ultra high doses for similar effects to opioids. So I'd like to kind of get more information and track that and see if we can't kind of head off some kind of snowballing abuse potential from that drug by figuring out how it's being used, where it's being used. And a lot of people that I talk to, when they can't get their buprenorphine, they turn to kratom because they don't want to return to use of a harder substance.
Actually, I think it's all of the above. We see it in mostly in high concentrations, I think, to achieve the opioid-like effect. And they are, it's easily accessible. And I guess it's cheaper. I don't know. I never checked the price, but I assume it's cheaper because it's, as I said, it's flea markets. And I think from the scene investigation, what we've seen is that they're ingesting it or actually even snorting it. And so, but we'll definitely pay more attention and then maybe dissect the data a little bit better, because it's becoming more and more frequent. We're encountering it more and more frequently in our cases. And as far as the other category, I believe that our reports are, especially if you're reviewing our medical legal death investigation report, are becoming more refined as you go from year to year to years. I'm hoping they're getting better. I think they're definitely getting better as we review them and as we go along. And a lot of that other category, other family members are frequently actually these men who are in their 30s and 40s who are still with their parents. And that's another thing. They live with their parents and they overdose in their bedrooms or in the basements, and they frequently have no jobs. And so that's something also to kind of look at socioeconomic sort of connection later down the road. Because you've seen that actually men are definitely dying more. There's no question about it.
Thank you. Yes, Michelle.
So, Jordan, what are you thinking about as far as today you were able to provide us with 25 cases? And so that's a fairly big number of cases for us to make thoughts and assumptions on, versus 3 to 5 that you might give us next month, and how we're going to be able to help you as a team, even if we provide you more information on those 3 to 5 cases. What do you think our role is going to be with smaller numbers of data points?
Right. Thank you, Michelle. I think that a lot of the movement here as far as team member inclusion is going to be being able to pull all that data together and create a real sort of narrative view, if you will, using the data numbers, and then using that information to create your own ideas and discussion. I do understand that since we are going to have smaller cases month per month, there's definitely going to be some data points where we're going to want to pull information from the previous month, track progress over time. I plan to include some of that data as well, just so we're not looking at just such a small data set every single month, so we can kind of track things over time as well. I think a lot of the team member contribution is going to be being able to take information from previous meetings and apply it to new cases. So a lot of times I think that's going to include, if you notice something that you've seen in the previous month that you're seeing again, or you're noticing over time, I feel like we talk about this specific point over and over again. Is there something we can do in this specific category, in this specific area of interest? I think that's going to be the big push for this team in general. Being able to notice those things and notice when you're pulling information, are you seeing some sort of similarities between the cases over time? Are you seeing very similar sets, like Drinko was saying? There's certain characteristics of each case that seem to be trending upwards or seem to be most common. Is there something we can do to reach that specific population or reach that specific group of people who fall into that category or overlapping categories? I think that's something we're going to be looking at a lot.
Jordan, this is Candace. When should we expect to be getting information from you? And also just, I have given the data sharing agreement to our Director of Compliance and Quality. So we're still working on getting that back to you, but I'm wondering when we should expect to see some information.
I'm planning to send cases within the next week or so for February's meeting. And I want to get your all's opinion on this before I make a decision. We have the option. I can either send you a larger group of cases and we can cover that larger set for the next 2 months. So basically your options are, I can send you 6 to 10 cases in the next coming weeks, and you have one set to get back to me next month, and then a whole other month for the other data set, just so you have all the case information now and you're able to have more time to pull the second round. Or I can send them individually. So I'll send the round for this for February coming up in the next couple weeks, and then I'll send the following one after the February meeting. Does that make sense? Let me know if I'm not being clear enough. Is there something that is there an option that would work best for you all?
I'm just going to speak for myself, Jordan. I would prefer to have it broken into smaller chunks because you giving me the cases, I'm still going to wait to the last minute to do the cases before the subsequent meeting anyway. So smaller chunks would be better for me personally.
Okay. Anybody else have any opinions on that?
Agree.
This is Jennifer. Jordan, I also agree. I think giving us a larger amount and then having us separate it into 2 parts could cause some confusion.
Right.
This is Sam Lee. I agree with Brian also.
Okay, great. Okay, awesome. I'm glad that you brought that up. So I will do that. So I'm just making a note of that here. Okay, so how that'll work is I'll contact Chris Thomas, and he'll pull the cases for me. He's going to pull the randomized cases using that search criteria, so that 25 to 44 age range. Again, we can revisit that at a later date, but for now, that's what we're pulling. It'll be recent data, so from the last couple months. I'll send that all to you all individually. We do need the data sharing agreement back in order for you all to share data with me, obviously. So if that's something that you haven't gotten a chance to look at yet, please let me know if you have any questions or any comments on that. And I can send it back to you as well if it's lost in your inbox. Once we have all those back, and you all can send me your data back by case number instead of by identifying information, I'll gather that, enter it, analyze it, and that's what we'll be looking at the next meeting. Before we move into like action items, is there anything else anyone wants to talk about during the brainstorming session? No? Okay, great. So last section here, again, our next meeting is February 11th from 3 to 4. I will update the calendar invite with the new Zoom link. So you'll probably be getting a calendar invite update from that. We will be using Zoom from now until that changes via executive order. So I'll keep you updated on that. If we do move to in-person, we can discuss that as well. For now, it's going to be held via Zoom. Again, we just talked about the first round of data collection. I'll send off the smaller set of cases. And again, I'll be emailing you all individually for that information. And as well with the data sharing agreement. If you all want to give me a call if you have questions, if you need some more time, totally fine. Just let me know. I'll be in contact with you all if I haven't heard from you. Just kind of touch base and see where we're at and see if there's anything you need from me.
Hey, Jordan, I have a quick question, if you don't mind. And it's just I apologize if I missed like the bigger picture. Is this going to be kind of similar to, let's say, child death review cases where we come up with certain sort of kind of conclusions, recommendations that are forwarded then to the State Department that would come up with some sort of resolution or incorporated into certain, I guess, annual reports or action items?
Yes, so we'll be collecting all of the ideas that we brainstorm as a team, and I'll be collecting those over time. And Lauren introduced herself earlier, but I'll be passing those off to Lauren, our external evaluator. Lauren will take that and some relevant information and run cost-benefit analysis. We'll come up with some ideas on what would be feasible in our community, maybe some community capacity building, process changes, anything of that nature. And we'll be tracking those on our end as well as in our reports as well.
And then give us the feedback, because that's one thing that it was kind of like not necessarily always done or was missing, and it still might be improved with the child death review, that we get the feedback as far as whether some of our action items have been incorporated or taken into consideration or even transformed into actual law, legislation, action, whatever happens from that.
Yes, yeah, we'll be keeping track of all that. And if we make any movement in the future on anything that has come out of this team, I'll definitely be sure to keep you all updated on that as well.
Yeah, thank you.
So if no one has anything else, does anyone have any other business to discuss before we head out? I want to be mindful of your all time. We just hit 4 o'clock, so I don't want to keep you too much longer. Does anyone have anything else? Okay. Well, again, I want to thank you all for coming today. I hope that this gives you a better idea of what these meetings and what the team is going to look like moving forward. Again, if you have any questions for me or need anything from me at all, please feel free to reach out to me. I have my contact information listed here. If you all need anything in the next couple of weeks or if you have any questions, please let me know. Again, I want to thank you all for being here, and I hope you all have a great rest of your day.
Thank you.